So the good news is they were going to give me an hour, but it's not that long because no one wants to listen to me drone on for an hour. So I could have named this PCN's, not a panacea, but it sure helps. And we're going to be talking a little bit about Alberta's journey with primary care networks and my own journey with primary care networks in Alberta. I do have some provincial leadership roles, and about half my time is dedicated to that. But I'm still very much a family physician. This is my home, Sylvan Lake, nestled halfway between Edmonton and Calgary. We get about 1.4 million tourists a year in the summer, which creates an interesting service challenge for us. Sylvan Lake itself is only around 15,000 people, and we have a catchment area of around 22,000. I work in a practice with 7 other docs, so we're a group practice. But we also do all the obstetrics for Sylvan Lake. We run an urgent care center in Sylvan Lake, 365 days a year. We do hospital medicine out of Red Deer. We have a large long-term care facility, residential care facility. We do community-based palliative care. So we still do qualify as comprehensive family docs. But if we're going to talk about primary care networks, I need to go back in time. And so I'm going to go back to Sylvan Lake circa 2003, 2004, which is when I started practice in town. And I joined 3 other physicians in town, 2 of which had been in town a very, very long time. And our clinic was an old liquor store in town, had the bars on the windows to prove it. Very much same practice style as now. The only difference was we didn't have urgent care in town, and I did rural emergency at that point in time. We are a clinical teaching site, so we do a lot of medical student and resident teaching as well. So not much changed in terms of the professional requirements from 2003 to 2004, but a lot has changed in terms of the service delivery. And when I joined Sylvan Lake, I had been the only new doc there in around 8 years. And despite that, the service pressures of a growing town in central Alberta were causing us to drown. And here's my first impressions: waits. We waited for everything. Patients waited for everything. I had the best wait in my practice of 23 days. Several of my partners, it was 90 plus days to get in to see them. That was the norm. Our waiting rooms overflowed into the corridor. And I ended up being more of a fireman than a physician, because I would just go from site to site where things were imploding, whether it be in the community, whether it be in a long-term care facility, whether it be the next sick patient that I was trying to squeeze into my practice in front of all the other patients that had already been waiting in the waiting room. And it really was a disastrous state at that point in time. And there are ramifications for that disastrous state for patients. So when you're sick and you can't get in to see your family doctor, where do you go? You go to the hospital. So high hospitalization rates for those with chronic conditions in my panel and in my practice. And I think the general sense in Alberta at the time, and the general sense in central Alberta especially, was that nobody noticed the stress we were under, nobody noticed the work we did, and nobody really cared. So I think an endemic feeling of feeling undervalued as a profession for the work that you were doing. And 3 years into practice, I contemplated going back to farming. Now, you have to understand that I hate farming. And now, I love living in central Alberta. I still live on my family farm, but I was a terrible farmer. And the only piece of career advice my dad ever gave me was, I don't think farming's for you. So for me, when I look back on it, this was really a hallmark of how bad things had got in terms of my enjoyment in my practice and some of the pressures that we were under. And we're really given a choice at that time, I think, as a group. We need to find a way forward, or we need to acknowledge that the way we envisioned practicing family medicine was not viable any longer. So I got to thinking, and you think about the evolution of medicine from 1966 to 2008. 2008 is when our primary care network in Sylvan Lake started. Does anybody know the significance of 1966 in Canadian healthcare? Medicare. So this is when they first started paying physicians to see patients as a covered service. And one of my partners who I became very, very good friends with had been in practice in Sylvan since 1977. And I asked him, well, what's the difference in the way you practice now, 2005-06 at the time, versus 1977? And what he said was nothing. My building's the same, the way I staff my clinic is the same, the way I schedule people is the same, the way I work is the same. The only thing that's actually different is medicine's gone and become a million times more complicated than it was when I started practice. So patients live longer, they have a higher chronic disease burden. The patients in Central Alberta became quite mobile and responsive to what is our major service industry, being the oil field in Alberta. So highly transient patient populations with more of a consumer mindset about medicine. When my family started farming the land I live on in 1966, they farmed it with a horse and plow. When they farmed it in 2008, it was with rather large equipment resembling that combine that I showed you at a much, much greater scale. The entire way farming was delivered and done dramatically changed. So I have to ask the question, well, why doesn't the provision of primary care change in a 30 or 40-year period? And when you ask new grads, they're not looking to get into the business of being the only person with sole responsibility for a panel of patients where they have to do everything. One thing that we did get right was continuity of care. And this is one of the pillars of the patient's medical home. So we maintain a literature review in Alberta, and this is from last year's. We looked at 112 articles around patient's medical home, networks of practice, and things like continuity. And it turns out that the most valuable thing a healthcare system can offer is a continuous relationship with a primary care physician. This is true in every country, it's true in every jurisdiction of every country, and it's true in every part of Canada. So we set off to measure that in Alberta, and here's what that looks like. So this is on resource utilization and talks about hospitalizations, length of stay, and cost. So if you're weakly attached to primary care, those giant bars are your chance of being in the highest cost category. If you're strongly attached to primary care, the pink bars are your chance of being in the high cost category. This is Alberta data. It's a logarithmic scale. It looks at something called CRGs, or clinical risk groups. This is how you segregate patients into how sick they are. And then intuitively, you would think the sicker you are, the more you're going to access and require specialty care. The pink line in the upper left corner is those with 3 or more chronic disabling medical conditions. And you can see from being weakly attached to strongly attached to primary care, their cost varies by 300%, from around $50,000 or $60,000 per capita to around $15,000 per capita. Lastly, believe it or not, in Alberta, your mortality changes based on your relationship to a primary care physician. This is all-cause mortality adjusted for demographics and patient population. And you can see your mortality, if you have a strong attachment, over 90% of your primary care visits are to the same primary care provider or team, your mortality all-cause is roughly half over a 10-year period. So the travesty is that if this was a pill, we would give it to everybody, because this is the single most valuable thing a healthcare system can provide its patients. So on one hand, we have the issue of practice burnout, functioning in an old model of care, trying to deliver continuous practice in the way we've always done it. The need to deliver continuity is the single biggest value of our healthcare system, and the two things are at odds. And it got me thinking that it's actually not the provider's fault, it's the system that we're working in's fault. And this is a guy named Edward Deming. And if you like things like process engineering and systems theory, like me, then you like guys like Edward Deming, who taught us that actually the outcomes you get from any complex system are 85% dependent on the way you put the system pieces together, and 15% on the skill of the people doing the work. So some things started to coalesce in my mind at that time in Alberta. And really what I decided is we actually need to take the leap and move into team-based practice. We'll get into some of the challenges of doing that as we go through the talk. The other thing that solidified in my mind is actually doctors aren't trained to do this work. We actually don't know how to improve our practice inherently. QI methodology is not our strength, nor maybe do you want them spending copious amounts of time on it. But family physicians need to understand this stuff in order to facilitate changes that happen in practice. The other thing that we looked at when you look at the literature is the value of practice facilitation. So I will tell you that if you have somebody with knowledge of QI to guide you through practice changes, you're about 6 times as likely to make those changes and be successful. And what we really were in desperate need of in Alberta was a sense of personal agency, which means the ability and the belief that you could actually make things better and make change. And primary care networks became the platform by which we tried to tackle all of these things. So I became board chair of a fledgling PCN called the Wolf Creek Primary Care Network, and this encompassed at the time 4 rural communities surrounding central Alberta. And what we did is we experimented and prototyped with just about every configuration of support that you can think of, whether it be chronic disease management nursing, panel managers, which is a modified MOA role, mental health support, social work, improvement facilitation, dietitian, foot care, seniors nurse, pharmacist, kinesiology, home care liaison, public health integration into the primary care practice. We experimented the crap out of everything for about 3 years, not all in one place, but actually tailored to the needs of the community and where it made sense. We actually systematically exposed leaders in every community and every practice to QI methodology. We gave them support in terms of practice facilitation to make the changes. And the biggest thing that we did is we networked physicians behind a common call to action, and we started to combat some of the isolation that physicians were experiencing at the time. In Alberta, as family physicians were driven out of hospitals in favor of other care models, as the burnout started to take its toll on primary care physicians, we lost the ability to interact with each other at some point in time. And what primary care networks did is they re-infused the desire and the structure to get together and talk about how we were providing care. And in BC, you're lucky that the divisions have taken on some of this role of bringing you together like you are today. When we started PCNs, there was nothing like this. It was really physicians in isolation practicing on their own. These are the 4 objectives of primary care networks in Alberta. So you'll see chief and foremost patient's medical home. Of course, we have a goal of being accountable with the funds we're given and effectively governed. We do need to think about the health needs of the community and population. And we really also have a mandate around improving some of the terrible transitions in care that patients experience in our healthcare system. But really, this is where we focused our effort, was how do networks actually advance patients' medical home? And really, the secret sauce is you give them a little bit of clinical support, you give them some facilitation to use that clinical support and actually make it better for them and what they're doing, and you help them connect to other parts of the healthcare system where they wouldn't have been able to connect alone. So it turns out that as an individual provider, your ability to connect with a health authority and negotiate how services are provided in the community, or how your services and the services of the health authority should be combined differently, is very minimal. But if you have a family practice, a primary care network, and you have a cohesive vision, you begin to be able to reach out to some of those partners and influence their thinking. It's important to note that as we did this, it does not look the same everywhere. The PCNs in Alberta have 41 distinct cultures. They have different geographies. They have different patient populations. They have slightly different programs depending on the needs of the population and community. But they're all oriented around providing practice support to advance patients' medical home and helping make practice better for physicians. So this can look like in a busy urban center where space is at a premium and you can't suddenly house a big team locally. This could be virtual. We have PCNs where services are 100% distributed, and that's the case in mine, All the resources live within my clinic and are part of my team. We have PCNs where the exact opposite is true. All the services are centrally located, and they provide coverage for a group of clinics in that area. We have PCNs that do this virtually, where geography is an issue. We have PCNs where the chronic disease nurse comes weekly to an office and sees patients independently. We have PCNs where they come 3 times a week and they work with the physician while the physician sees patients. So there's a lot of flexibility in how you get there, but the goal, core objectives, and the framing of how you get there are the same. This is our pyramid scheme for scaling up medical home in Alberta, and I'll tell you a bit why it's important. One thing that we have is a cohesive vision at a provincial level around how we see advancing patients' medical home and how we see changing practice in Alberta. We work hard on supporting physicians in every zone who have key leadership roles in every zone. We also support the 41 leads of each PCN. Those individual PCNs support their member clinics, and our goal is to have a physician champion in all 1,000 or so member clinics in our province, supported by 200 full-time practice facilitators throughout the province. And this is really a wedge design to get into changing the practice patterns and the way care is provided for all 4,000 primary care physicians in Alberta and their 10,000 team members. And know those 10,000 team members are not all from PCNs. The vast majority of those are employed by clinics, like it is anywhere else. So what did we learn? We learned that we need to have that tie at each level of the healthcare system, because part of our job is to influence how policymakers think, how funders think. Part of our job is to influence how our own colleagues think and help them vision how they might be able to change their practice or incorporate some of these team supports. Highly borne out in the literature and also through our experiences, chronic disease management and using team-based care to look after your sickest patients that take you the most time or are the most complicated probably has the biggest bang for its buck across most settings. And so that is one of the areas where many PCNs have focused. And then the principle of mass customization, which is that this is not going to look the same in every area in BC. It's not even going to look the same in every area of Victoria. And even in an area in Victoria, it probably is not going to look the same in every practice in that area. So how do you use PCN supports as the wedge to transform practice, to help physicians make the changes they want to make, but make it in their own context? The question I get asked a lot is, well, why did physicians buy into this? So basically, if you're a primary care physician in Alberta, you're in a PCN. There are a couple holdouts. I won't name names, but there's a couple out of the 4,000 that are holdouts. But pretty much, if you deliver community-based primary care, you're in a PCN in Alberta. So the question is why? Because it means I have to do something else. It means I have different relationships than I might have had before. So why would I do that? And it turns out that the reason physicians do stuff differently is actually no different than the reason anyone does anything differently. And if you've ever read Dan Pink's book, Drive, he talks about autonomy, mastery, and purpose, which is really what drives humankind. And so for us, what we did in Alberta with PCNs was give a cohesive purpose, a calling, a direction to practicing family physicians as a whole. We also let them master how they use teams in their own context. And we provided them support to become experts or masters in how I work in a team, how I work differently. And we provided individual autonomy at a PCN level on how do you get this done? How do you mass customize this approach so it makes sense? But the new autonomy of the future is not the autonomy of old, where a primary care physician does whatever he wanted, saw whoever he wanted on his own time or her time. It really is autonomy, but with accountability. And what I'm going to tell you is across the province, there's a culture clash of the old autonomy physicians used to have and the new autonomy that society is demanding of them, which comes with accountability and a need to change. But physicians in Alberta have really bought in to the PCN movement and the practice transformation movement because we're really focused on allowing them to maintain some of that autonomy while giving them a purpose and allowing them to remain masters in their field. And this is some of the old paradigm to new paradigm changes that you see. Solo practitioner practicing alone to physician in team. Ironically, there's a handout on PCNs at the back that I read that has a lot of this stuff actually on it. And it talks about moving from the old way we used to do business to a new model of care. I'm not going to read them out or bore you with reading them, but it's about being organized to look after a population, reconsidering how you deliver chronic disease management, how you deliver screening, how you deliver access, versus relying on a physician-only gateway to access care in an unsupported way. There is nothing in the world that comes for free. And here's the balance of what we saw in Alberta. If you want to change, you have to invest some time. There is nothing in life that will change without you investing that time. If you want to be valued by your partners and you want to be valued by society, you have to be accountable to them. That's the way life goes. When you reach out to partner with new people and you want to partner with your health authority and you want to partner with other health organizations, be aware that those partnerships come with expectations and you have to manage those expectations or work with your partners to reframe those expectations. And if you really want to consider what's possible, you actually need to let go of something that you hold dear. And a lot of physicians hold very dearly how they've been practicing for a long time. So change actually comes with trade-offs. It comes with investment. Despite that, we see physicians taking this on because they believe that the practice they have now, supported by PCNs, is dramatically different and more satisfying than the practice they had before without PCNs. I don't like to give a heck of a lot of advice, but I'll give you some bullet points over a couple slides. So what I want you to remember is that non-clinical staff are just as or more important in implementing networks than clinical staff are. So what do I mean? If I simply took your practice and I popped in a chronic disease nurse and a pharmacist and an LPN and we said go to work, it would be a disaster. It's a disaster for everyone except about 3% of physicians who will figure it out on their own without any support. The other 97% need support to make the changes. And we talk about practice facilitation and a role called panel managers, which are really a nursing role in helping you manage your panel of patients at a practice level. Be prepared that whatever you set out to do will not be the thing that you end up doing to be most successful. This is a continuous improvement mindset. You will have to adjust your plans as you go. There is no place where they said, we have the plan, we put the plan in place, and it was perfect. You need to do this in a staged fashion. You need to gate the changes you're asking of primary care providers. Otherwise, they will become burned out and overwhelmed. And it's a paradigm shift for practices that doesn't go away, and you need to engage members throughout the entire process. Please know what you're trying to solve with PCNs. There are good ideas, and then there's good ideas with a purpose. And you should actually know what you're hoping to get out of PCNs, meaning you know the outcome you're looking for, the problem you're trying to solve, but allow the providers in the middle the maximum flexibility in how to do it. And this is the principle of tight, loose, tight. Provincial frameworks, they're helpful in terms of drawing the boundaries on what you can do. Provincial frameworks are pretty lousy at telling you how to implement change. And I think you really need to rely on the expertise of the divisions and those types of supports to help you with that. Provincial primary care organizations need to be on the same page. When we started in Alberta, we weren't. So the sections under our medical association were at odds with the leadership of primary care networks, were at odds with the leadership of our provincial college of family physicians. And we took time and effort to get everybody on the same page, and we maintained the effort in keeping them on the same page moving forward. you really need to target the health authority partnership early on, and you need to work out the details of that partnership. At one point in time, our health authority was told by the government they weren't allowed to talk to PCNs or partner with them anymore. These are some of the drastic things that happen around government changes. But here's the thing. We were organized, we knew what we wanted, we knew how to approach it, and we survived that storm. And in the end, the partnership ended up stronger than ever. You need the change management support to do it. Do not underestimate the supports required, but your goal is not to make physician clinics dependent on your support. Your goal is to make them self-sufficient and have the knowledge, skill, and ability to continue to work on patients' medical home by themselves with minimal support. Governance is critical. If you're getting into fledgling primary care organizations and you're getting into complex partnerships with a health authority, make sure your physician leaders have good governance knowledge and training. Ours didn't. We had to retrofit it, and it cost us a lot of momentum to go back and do that. Leadership is crucial. You have to share with each other successes, failures, challenges. You need to support your physician leaders administratively and mentor those new docs who want to take this on. Make sure they're supported to do it well. And include patient advisors. So happy that you guys have a patient advisor on your board already, but include patient advisors in all levels of design right from the start. So we get together under the banner of the Primary Care Alliance. Those are all the major primary care organizations in our province. The leaders of these organizations volunteer to meet once a month to move the patient's medical home agenda forward. We are strongly supported by our medical association. We are absolutely extremely lucky to have the largest change management organization under a medical association supporting us. And we do exist in a provincial governance structure where the leaders of primary care, networks have a direct line to the minister and the deputy minister of health in our government. And that provincial committee really works on setting the strategy and the focus for PCNs, while at the zone level in PCN, they work on implementation. So when I started in my role in 2012, 2013, there was a handful of physicians who understood medical home, some basic QI stuff and where we were going as a province. In 2018, our last numbers were 476. So I would have a list of 476 docs, and these docs have specific interest and physician skill and specific skill. They might be EMR champions. They might know a lot about how to implement teams. They might know a lot about how to manage chronic diseases. They might know a lot about panel cleanup. They might know a lot about practice management. They might know a lot about how to govern a PCN. But we have a wealth, an embarrassing wealth of physician leadership in our province that actually makes this possible. And please remember to have fun. Our events are not boring. We take time to celebrate and have fun. The left picture is actually my clinic last Halloween. The bottom right picture is a group from our PCN at something called Change Agent Day, where we bring together all the leaders working on implementing medical home and PCN operations in an event called Change Agent Day, where we give them tools and skills and networking to help them be successful. And the top picture is me and a physician colleague from Pincher Creek doing a Dr. Evil and Austin Powers bit for one of those events. I have to know you really well to get the link to that video. I want to leave you with, what can a team do? So I'm not going to read through this, but this will be my last slide, and I'll leave it up while we take questions. So in my team, these are things done by various allied health and team members. And what you can see is it spans everything from chronic disease management to acute care management, to geriatric assessments, to managing hypertension, managing anticoagulation, dealing with complex mental health conditions. These are supports that I've built over a period of 10 years in my clinic with PCN support and other supports in place. So I encourage you to dream big and ask yourselves what could happen if we had PCNs in Victoria? How could our practice change? What are the good things that we could take and learn from this and apply it with your own mass customization in your context? So I think I'll leave it at that. I want to leave time for some questions, and I know we were running a bit behind. Is that okay? If anybody has questions. Specifically didn't cover funding or physician funding or governance or IT or Bill 21 or any of those things, but feel free to ask.
I just have two quick questions. The first, I had heard from a colleague recently who practices in Calgary, that in Calgary his PCN informed him there were 800 family doctors looking for patients. Do you know if that's like approximately a correct number? Because that would be shocking to us here in Victoria.
Yeah. Calgary is I don't think it's that high, but Calgary is actually an incredible anomaly in our province. And what happened during the boom times is Calgary's physician population swelled, and then the population and business of the city shrunk. And so there is actually, for sure, physicians taking patients in Calgary. You can drive 45 minutes in any direction of Calgary, and you can find places where they're horrendously short of physicians with incredibly long waits and incredible pressure to get the work done. Calgary is an anomaly, and there is truth in what you're saying.
The other question just is a question about funding, because I know that PCNs do amazing stuff in Alberta, but my understanding is that they also get funded very well to do that. And I've heard numbers before, like between $50 and $75 per patient per year within a PCN, which is a huge amount of money. And I don't think that's the amount of money we're talking about here in BC for the rollout of our PCNs. And I was wondering if you could just talk quickly about that funding piece.
Yeah, sure. No, I'm more than happy to talk about it. Yeah, so 62 is the number. So $62 a head. The way they actually cut the funds is complicated. They use four-cut methodology, which means a bunch of patients actually get left off in the end. And so it really only pays for about 75% of the patients in Alberta due to the way the funding methodology rolls. $62, if you do it over our entire population, it's around $250 million as a province is what invested. Our provincial healthcare budget's about $20 billion, and so it's roughly 1.5% of funding in our province. The question I get asked is, what would you do with 30? And the answer is the same thing, we just wouldn't have as much. The approach wouldn't change. I wouldn't change anything about it except that we wouldn't have as many supports available as we have now.
I'm curious about the patient experience in terms of, I think one of the things that concerns long-term family physicians is the rapport and the connection they have with their patients. How does that change both from the patient perspective and the GP perspective in a team like this?
Yeah, so the literature says that GPs have more trouble with it than the patients do initially, for sure. So patient satisfaction, we have tools to measure patient satisfaction. It's one of the indicators for PCNs. They're required to measure some degree of patient satisfaction, not the same in every PCN. Pretty ubiquitously with team-based care, the satisfaction of patients for the most part goes up. There's a small segment of the population that only wants to see their family doctor. And there are some that you have to work on to see the value of seeing an allied team member. So I guess I'll give you this example. There's a big difference between somebody coming in to see me for their diabetes and me saying, hey, if you want to see Barb, you can book an appointment with her. She might be able to help you with your diabetes. Or Barb is a member of my team. I trust her with my diabetics as much as I trust myself. I think you're going to get a better experience if you see her as well as I. She'll communicate everything she does back to me. I'm there to support her if she has any questions, and this doesn't change the relationship you and I have. Far different message, received far differently by a patient, setting them up for a far different experience. So how physicians choose to pass the halo to their allied team matters as much as just having the team there. But if you want the evidence, patient satisfaction generally goes up, physician satisfaction generally goes up.
Can I just ask, in most circumstances, who's the employer of the other team members?
So of the PCN staff, the primary care network is the employer. So now you're going to ask me, well, why would I want somebody working in my clinic who I don't employ? And so what we do have is the concept of service agreements between clinic and PCN. So this is a two-way agreement whereby the PCN agrees you to provide services to achieve certain goals in your practice. And as a practice, you agree to provide them with whatever they need to be successful. And that looks different depending on the model that you're in. Many clinics have very close relationships with their PCNs. If they're hiring somebody who's going to be a full-time employee in their practice, often the practice is part of the hiring process for the PCN itself. And what you have to remember is really what you have is a hybrid model, because as a clinic right now, if you have no support, you have staff, right? You'll have a receptionist, you have an MOA. It's not like they go away, but you add to it. So you end up with a hybrid model where I pay some of my staff, my PCN pays some of my staff. And actually in my practice, I actually have seconded health authority positions in my staff too, through another complex arrangement that I have with them. But in Alberta, PCN funds, the staff are paid for by the PCN themselves.
There we go. Thank you very much, Brad. Very inspiring. The way you described the feeling of undervalue back at the beginning of your journey parallels exactly what we're feeling here. And then you said, if you give people mastery, autonomy, and purpose, they start to feel value. What we feel like, though, is value is also shown by dollars in my bank account. Showing me that I paid similarly to a hospice or to someone who works for WorkSafe or something like that. How did you manage? I assume your physicians were also setting value with money, not just a really inspiring project. How do you handle that?
Yeah, so I can still make more as a hospitalist than I can as a primary care doc. I actually did some of that work in a transition in model. So we have the same issue. So physicians in focused practice, physicians in hospitalists, physicians in other arrangements can still make more than the community-based doc, for sure. There's a pay disparity between Alberta and BC, no doubt. And so primary care physicians, well, every physician in Alberta makes more than physicians make in BC. So I think maybe there's less pressure in Alberta to start with. But actually, the honest truth, and I'm not lying, is that the physicians never said the solution was to give us more money. And actually, over time, the small portion of them that said the solution is to give us more money has gotten smaller and smaller and smaller. To the point now when we talk about probably a fiscal deficit in Alberta and a renegotiation of our contract that will not be positive under our government change, the physicians are not talking about the loss of dollars. They're talking about how do I preserve my team support in whatever the arrangement looks like moving forward. And how do I preserve my change management support that my medical association gives me? So no doubt, if you can't pay the bills, you can't keep the lights on, and you're under financial pressure, it's hard to do anything. But actually, the surprising focus has not been on that. That being said, we continue to work on fee reform and other alternate payment options that incentivize comprehensive family practice. So PCNs are only part of the solution of the future. We do need to reform physician payment, and there's several things in play in Alberta that are working on doing that as well, because I do think it's still an unbalanced playing field as it stands right now.
Just a quick question here around liability. You've had this for a few years now, so probably had enough time to see what happens when a negative outcome occurs in a shared care model. And I wonder if you could speak to that.
Yeah, and so I don't think it's been any different than a bad outcome that would happen in a non-shared care model. In fact, I don't have a study to pull on this, but what I can tell you is what people tell me is sharing the mistakes or bad outcomes that we make as a team is easier than burdening the mistakes or outcomes alone.
Is that the patient's perspective and the patient's lawyer's perspective?
Well, yeah. Good question. So, I mean, we're working on, there's actually big issues. So there is actually no case law around this. The college standards are horrifically out of date in terms of how you manage team-based care. Up till recently, they really didn't even understand at the college level what a PCN was and what the responsibility of the board and the medical director are for the liability of their staff working in clinics. So we don't have that sorted out. We're certainly aware of the issues and working on it. Has there been any mind-blowing headlines? No. There's mind-blowing headlines in healthcare and its deficiencies every day of the week. I don't think this has caused any more. But there are a lot of legal, regulatory gaps in terms of legislation and practice standards that need to get filled.
This is all really interesting and really timely for all the work that the division here is doing. I just had a question. You heard a comment earlier about how within 100 meters of a colleague's office that 7 practices have closed. What's your experience been in Alberta for regions where they're starting from a deficit of physicians already, and so significant pressures for physician qualifications?
Yeah, I mean, I hate to draw causation between PCNs and physician numbers, because I think there's a whole bunch of factors that go into why physicians choose to practice in community or not. What I can say is the trend is positive in terms of community-based physicians in under-resourced areas of the province. Predominantly rural is our biggest challenge in Alberta. But we actually don't know if that's all on PCNs or if that's payment reform or if it's the effect of our rural residency programs, which are driving more residents into rural settings. The underserviced areas are interesting because often in underserviced areas of inner city, there's actually models in play already that look after those patient populations. So we have a family care clinic in downtown Calgary, something called the Boyle-McCauley Center, which is an alternate relationship plan. We have clinics with different payment mechanisms and team-based care already that were there before PCNs were ever there to look after those populations. Empirically, new grads will not take over your solo practice. I'm sorry, it's just not going to happen. That's across the country, by the way. New grads want to work in a team, they want to work in a group, and they want to be supported. And what we see is if you can build that kind of environment, we are attracting grads to community-based practice. One of the challenges in even measuring that is knowing what docs are actually doing is incredibly difficult from our current information. And so knowing how much of my practice is a hospitalist practice versus a community-based practice versus a specialist interest practice in Alberta, very difficult to figure out right now. And it's actually one of the things we're working on this year is how do we measure that and track that better over time.
I'd like you to speak, if you could, to the notion and the advantages that you believe exist by having physicians involved in the corporate structure of the primary care process and agree to physician owned and operated primary care networks.
Yeah, so I mean, physicians form a not-for-profit corporation. There's a physician board that runs the PCNs. The important distinction is that it's actually a joint venture partnership with the health authority, which means physicians can't submit a business plan that the health authority doesn't agree with. And so it is a joint venture. Health authority has to agree with what the physicians do. The sale, to be honest, is that if you want changes in community-based practice, you have to have leaders that work in community-based practice that understand it to help make it work. And I think that the what they've seen is that if they want changes at a practice level, PCNs are the vehicle to do that. The reason they're the vehicle to do that is because of the relationship and the leadership of physician leaders that run PCNs. And if they took that away, it makes it much harder to achieve.
Physician champions are key to the organization of this, and what orientation or training is provided to them so that there is some commonality in their messaging and communications with people they serve?
Yeah, so that's on me, I guess. That's part of my job. And so we have something called the Physician Leadership Network. And so there is actually everything from webinars that talk about just the system, how it works, the different players, their roles, to webinar calls where we will go over a topic and answer questions that champions might have. We do stuff like the Change Agent Days, which you saw, where we bring those champions together around shared messaging. There's communications that go out to those individuals as well. There's training opportunities that exist for the improvement facilitators as well as the physicians together. And every time we bring forth something called a change package, meaning something we're looking to put in practice, say opioids, which is a big one nationally right now, there will be a set of changes we're looking to put in place in PCNs in practice. There will be a curriculum for improvement facilitators and physician leaders. Then they would have the support of the association as they moved into networking with their colleagues and peers. So is it perfect? No, still got a ways to go, but it's actually pretty good, I think.
May not be perfect, but it sounds impressive.
Yeah, sure. I'll be around.